So I'm just going to speak on recurrent retinal detachments and what is it exactly? It's a redetachment of the retina after a successful primary retinal reattachment surgery. And although the failure rates have decreased due to advances in surgical techniques, it is a reality that every VR surgeon has to face from time to time. This can occur post a pneumatic retinopexy, post a scleral buckle, or post a vitrectomy. Causes of redetachment include the ineffective closure of the break at the time of the surgery. It could be happening because of missed breaks or new breaks or the development of macular hole. But the most common cause is PVR, which is proliferative vitreoretinopathy. How do you go ahead with such cases? Options include a pneumoretinopexy, a revision or addition of a scleral buckle, a vitrectomy, or membrane peeling under oil. So if you have a recurrent retinal detachment after doing a buckle, you can either augment, this is something we don't do very often nowadays, but it used to be done a lot in the past, to augment the buckle or modify the position. And with this, some cases you may avoid a vitrectomy. So this was a case which we had done some time ago, and you could see well on the opto's picture, a nice buccal effect, but there's some fluid inferonasally because there was a superior break. This was a phakic 40-year-old patient, so we are not very keen to do a vitrectomy. And this is how the revision buckle was done. So you can see we just added a buccal piece, and this is added in the superinasal quadrant, and this is an addition to the buccal piece already present there. Of course, this was done fairly recently after the surgery, and it helped. And you can see it attached retina after this procedure. Rescue pneumatic retinopexy also has an important role in this study. 100% of the buccal group and 90% of vitrectomy group got repaired with pneumoretinopexy. But the main thrust of our talk today is revitrectomy. So let us concentrate on this and see how to do this in a stepwise approach. If there's a cataract, like Dr. Daraj also mentioned, to get rid of it, it may require a phaco or you may need a lensectomy. If the IOL is stable, because especially in cases with a lot of anterior proliferation, you may need to remove the IOL. You may need to use a temporary keratoprosthesis if there's a corneal haze, or do endoscopic vitrectomy. Decide the gauge and decide about putting a buckling element. Why put a buckling element? I believe it's very, very useful. It reduces the circumferential and anterior posterior traction. It helps to isolate the peripheral retina from posterior, forming a new, more posterior ora serrata. And it is very useful supporting large or inferior breaks. Spend time on membrane dissection. This is because anterior PVR is more commonly seen in vitrectomized eye. Normally, we find that the previous surgeon or ourselves have left a large uncut vitreous skirt causing it, then move on to posterior PVR, remove the subretinal bands or subretinal silicone oil or PFCL as we saw, do the ILM peeling, roll of retinectomy, of course, has already been discussed, and then decide about the choice of tamponade. So this is a case I like to go through from the beginning. This is a case which was already vitrectomized, and we can see the oil is removed. We weren't getting a good view, so there was capsular phimosis. So this is just to show you some simple steps can help to improve the view. And when we look in, it's quite horrible. It's like a napkin ring configuration. So we put a chandelier. I think bimanual surgery has revolutionized these procedures now, because with both hands we can do so much more, and it is much more atraumatic. So now we found the cause of this is a napkin ring. And I think we all have done this when we try to pull these bands with one hand and then we leave it, it goes back like a snake goes back in the hole. So this hand upon hand technique is quite useful. And as you will keep seeing in this video, it's not just a single band. It seems to have a lot of tentacles, and removing it is quite a challenge. So fortunately, without resorting to a very large retinectomy or anything like a 180, just by removing off this band, which you can see is now floating around with its tentacle, this helped to settle this retina, and now we're doing laser and feeling much better about it. So I think that's the end of this case. Just a few tips and tricks since we're on this topic. One was a small tip on how to locate an occult break. This lady had a recurrence 2 years post silicone oil removal. There was an inferior shallow RD along with previous laser marks, but no obvious break was seen. We tried to locate the break with the help of Schlerin with a brush needle, but we were unsuccessful. It's a very shallow RD in this case. We thought out of the box and made a 38 gauge retinotomy and slowly injected subretinal brilliant blue dye. As the dye filled the subretinal space, we had a eureka moment. We saw the blue dye emerge from a very tiny temporal break near a laser mark. Once the break was found, we removed the dye with a brush needle, then performed the fluid air exchange and settled the retina. So just something simple in a case which is challenging. The other tip which I'm personally very fond of is the tug of war maneuver, which is very useful for anterior circumferential PVR. So there'll be a video on this. I like to perform a maneuver called tug of war, based on the shearing force a rope undergoes during the game. We use opposing forceps to tug and shear the membranes gently and relieve the traction without resorting to a retinotomy. See this young, highly myopic girl with circumferential traction bands predisposing to anterior PVR. This maneuver allowed us to bimanually release anterior circumferential traction. We took two forceps at 180 degrees to each other, then pulled and shredded the bands holding up the retina. Once the bands were separated from the underlying retina, they could be safely trimmed by the vitrectomy cutter. As the traction was released, the retina fell back and settled without requiring any retinotomies. With a sigh of relief, we performed laser to the attached retina. So I think this is another example of tug of war, but I think we'll just skip this slide. And this is something which we published as an original article in the Indian Journal of Ophthalmology, and it was out in the October issue. It's free online if anyone would like to see it. Let's move on to the next topic about membrane peeling under silicone oil. So this is very useful for recurrent retinal detachment with focal lesions of PVR. And here the infusion cannula is connected to the oil infusion, and intermittently we have to keep on injecting oil to maintain the IOP, and focal traction is released by this maneuver. So just a short video on that. So this is a recurrence under oil. And here we can see we are peeling the membrane under oil. We are not getting too much counter traction. So again, we put a chandelier and we do the bimanual dissection under oil. So here the forceps and the scissors are being used. Scissors in the right hand, forceps in the left hand. I think we have to be very patient in these cases, but slowly and slowly we get rid of the membrane, and we do a fluid silicone oil exchange at the end of the surgery to settle the retina and do the laser. So just coming towards end about tamponade. So what is silicone oil? So heavy silicone oil is basically something which has been designed to overcome the disadvantages of routine oil or gas. These are heavier than water tamponades, and they could endotamponade of inferior and the posterior pole in the normal positioning. So these make, there's no need for face down positioning if you use this. Of course, we use it very, very sparingly, but it has a special use because the surface of the lower retina periphery is what is not normally covered by the tamponade. And this is where the PVR soup, where the mixture of aqueous humor and growth factor accumulates, and invariably we are frustrated by this inferior PVR. So this is very useful in some of these cases. So basically RD with PVR or with open inferior breaks or membranes are the cases we use this, or patients with positioning issues. These are the ones who benefit maximum from this. But please remember, this is not a substitute for doing a good surgery or complete removal of traction. And if inferior and superior tamponade is required, it may not be a good idea. And of course, it is very, very costly and not easily available. So this is a very busy slide. Let me just take you through it. So if we have a recurrent RD and it is post-vitrectomy, and if we've had a oil removal or the gas is gone, then there's only one option, which you can see on the right. We have to do a revitrectomy, membrane peeling, endolaser, oil with or without a belt buckle. But if we have a silicone oil filled eye, then there are certain options we have. So if there's only inferior break with no PVR, we can just add a scleral buckle, or if it is peripheral, we can add a laser. If they are focal membranes, like we discussed, then you can do membrane peeling under oil or a tiny relaxing retinotomy, which Dr. Dilraj said, for the localized area. But if there's PVR subretinal gliosis or if there's extensive subretinal oil, then I would definitely recommend a silicone oil removal, membrane peeling, manage the lens, use PFO to help you, do as much of a relaxing retinotomy as required, do laser, and re-inject the silicone oil. So I think the Brahmastra has already been discussed by Dr. Dilraj. So thank you very much. And these are my acknowledgement. So I would like to acknowledge Dr. Kunal and Dr. Dhanashree ma'am also, because this was a part of an instruction course we had given in URetina also some time ago. So thank you, everyone.